screen now?
Yes. Can you put the first slide that I sent to your mail so we can have the slide for this event presentation?
I can see the presentation, and you can see it too?
Yes.
Okay.
María, si le podemos pedir por favor que suba un poquito la cámara para que no quede tan abajo.
Que suba la cámara. Que lo escuche así.
Correcto, así.
Oye, ¿y ese pantalla lo podemos cambiar primero de portada? ¿Lo podríamos cambiar después?
Oh, I cannot see now.
Porque no pone la otra. Okay, so can you move your camera so you are more centered? You can put it, you have more space from your head to the ceiling.
Like that?
No, less. It's
less. I cannot see me.
Yeah, there it's better, no? Let me ask them.
Perfecto.
¿Está así, no?
Perfecto, así.
Okay. So first, Dr. Dupont, we're gonna first do the presentation, and after the presentation, we are gonna do two frequent asked questions, and I will let you know these questions will when you stop your presentation, we'll stop sharing your screen, and then I will let you know how we are gonna do these questions.
Okay.
So this. First, just to say hi, we don't want to say good evening or afternoon or anything because it will be a recorded session. And from that on, I think we are good to go. So before you begin...
It's good evening, good afternoon. What is it?
No, don't say anything. Just welcome.
Okay.
Just welcome to this presentation. I'm thinking, can you remove the July 8th from the presentation?
I remove this?
Yes, because some countries will have it on July 16 and some on July 18. So then, yeah.
So remove this.
Yes, thank you. Yeah, that's perfect.
Okay. And okay, so now it's okay for you?
Yeah, that's perfect.
Okay. I share the screen again.
Yeah, we can see it, right? Yes,
it's good
perfect.
For you?
Yeah, we can see it perfect.
Okay. If I miss a slide or something like that, I can go on with the presentation and you will cut what it is. If there is a problem, you can cut and reassemble it without any problem. No.
Yeah, if you make any mistake or you want to repeat a slide, just count over to 5 on your head and begin the slide again, or go back to the slide you want to record again. So you can give us some time to make the right adjustments after with the video edition.
Okay. So I count to 5 and then I start again. Okay, that's right.
Yeah. That's right. Okay. Perfect.
Count down, count up, down.
Oh. Just count 5 in your head.
Okay.
1 just in your head.
Okay.
Okay, perfect. So just to begin, you will do the same. You count 5 in your mind and then you start talking.
Okay.
Okay?
Okay.
Perfect. So I think we're ready to go. Let me ask them if they need to do any other adjustment. ¿Así estamos bien? ¿Ya estamos listos?
Sí, ya estamos grabando.
Perfecto. So we are good to go. I'm going to be off the stage now. Good luck.
Thank you. Ladies and gentlemen, my name is Christophe Dupont. I am a professor of pediatrics working in Paris, and it's my pleasure to talk about cow's milk protein allergy. And the title of my talk is Rethinking CMP Management Beyond Diagnosis. The diagnosis of cow's milk allergy to cow's milk is a little bit complicated because it is represented by a large array of symptoms, and it is important to recognize the symptoms, and it is important also to assemble the symptoms to be sure that we go to the diagnosis of cow's milk allergy. There are different types of food allergy. You may have IgE-mediated allergy, and these IgE-mediated allergies are the ones which are recognized by the skin prick testing and the measurement of specific IgE. You've got the non-IgE-mediated allergy, the ones that you see mainly in children when they are very young, in infants actually. And you've got the eosinophilic disorder, which is an entity progressing at the moment, and eosinophilic disorders, including eosinophilic esophagitis, is something which is just between IgE-mediated and non-IgE-mediated allergy. So when it comes to milk, it is interesting to see that milk is a food which is involved in any kind of allergy. You know, for some foods, such as peanut, tree nut, sesame, or kiwi, allergy is only IgE mediated, which means that if you have, for example, the idea that the child may be allergic to peanut, then you will do a skin prick test and you will measure the specific IgE. And if it is positive, you've got the allergy. If it is negative, then allergy is not present. But this is not the case all the time for milk. You may have milk allergy with high specific IgE with positive skin prick test. But you may have allergy to milk, which is absolutely non-IgE mediated, which means that skin prick tests are negative. Specific IgE in the blood are also negative, so that you have to diagnose cow's milk allergy only on the clinical symptoms. And this is the difficulty, because in infants, in children less than 1 year of age, milk allergy is most of the time non-IgE mediated. 80% of cases are non-IgE mediated. So that it is important to recognize the symptoms. So how to recognize the symptoms? There is a very nice paper which has been published by the IMAP group, which describes very precisely the symptoms of cow's milk allergy. And you will see the symptoms in the different tables that I am going to show in the next slide. So let's go to this IMAP publication. You see in yellow the non-IgE mediated allergy, and you see in blue the IgE mediated allergy. You've got the mild to moderate here, the severe here, and here the mild to moderate. It's a little bit difficult to read because there are too many information on this slide, so we are going to focus on a smaller panel with here what is the most important, the most frequent, the mild to moderate non-IgE mediated cow's milk allergy, with also here the mild to moderate IgE mediated cow's milk allergy. So again, IgE here and non-IgE here. What do you see? You see that you've got gastrointestinal symptoms and you've got skin symptoms. GI symptoms are irritability, vomiting, reflux actually, food refusal or aversion, diarrhea, constipation, abdominal pain, even blood in the stools. And you've got the skin. For the skins, the main symptom is atopic dermatitis. You've got the symptoms also of IgE-mediated allergy, which are more, let's say, quicker. And these symptoms are acute pruritus, for example, urticaria, and for GI symptoms, acute vomiting or diarrhea. What is important to recognize that is that very often the diagnosis of cow's milk allergy is failed because when a child comes to the doctor with vomiting, immediately he is considering as having reflux or gastroesophageal reflux disease. He is treated by PPIs, anti-acid products, or sent to the pediatric GI. And when a child, and if the same child has got also atopic dermatitis, he will be recognized as someone with atopic dermatitis, being treated with steroids or sent to the dermatologist. But as you can see here, you've got the treatment of reflux on one side, you've got the treatment of atopic dermatitis on the other side, but the diagnosis of cow's milk is not done. Actually, when you've got reflux and when you've got atopic dermatitis, you've got almost certainty that you've got cow's milk allergy. So that when you've got a child with reflux, the first thing to do is not to go to PPI, but the first thing to do is to ask for the presence or not of atopic dermatitis. And if you do that, then you have the association, and this association is really typical of cow's milk allergy. Actually, cow's milk allergy is a vast array of symptoms. You may have reflux, you may have atopic dermatitis, you may have crying, you may have problems for sleeping disorder, you may have food refusal. The important thing is to recognize that when you've got this and this and this means cow's milk protein allergy. So cow's milk protein allergy is a diagnosis which is easy to do if one is thinking all the time about the thing that when you've got one symptom, you need to try to find the other symptoms to go to this association indicating cow's milk protein allergy. In order to ease the diagnosis of cow's milk allergy, we are a group of let's say, specialists of cow's milk allergy who have decided to set up a tool, an awareness tool of cow's milk allergy. The name of this tool is COMIS, and it is designed to help people to take into consideration the potential diagnosis of cow's milk allergy. This is why we labeled it an awareness tool. When you look at this tool, you see the symptoms: crying, regurgitation, stools, skin, respiratory symptoms. You can analyze the symptoms, you can grade the symptoms, and then the total of the symptoms leads you to, let's say, 9, 10, 12. At the beginning, we thought that 12 was a threshold above which were the almost certainty of cow's milk allergy. And following a lot of work being done on this tool, we think now that the threshold is at around 10. We think that this tool is very useful, very important. This is why we decided also to help the parents use this tool, and we labeled this tool for the parents the pre-COMIS tool. So that you see that milk is important, very important, because we need to recognize the cow's milk allergy in infancy, based on the different symptoms that we were talking about before. But it is important also to see that milk is also responsible in what we can label new syndrome of allergy. One of them is eosinophilic esophagitis. What is eosinophilic esophagitis? It is some kind of eczema of the esophagus in which when you do an endoscopy, you see a modification of the mucosa with edema, white plaques, with longitudinal furrows. When the disease develops, in the end, you may have a modification of the motility, and you have the esophagus looking like a trachea. And in the end, you may have a stricture, and the food may be impacted inside the esophagus. So that it is very important to recognize this eosinophilic esophagitis. You see here the development of the lesions, more inflammation in children, and stricture in adults. The important is to try to prevent the evolution to stricture, so that we need to be able to recognize the potential eosinophilic esophagitis when the child is young, and the symptoms, the main symptoms, when the child is very young is reflux, and when the child is older, a male usually around 7, 8, 9 years of age, is abdominal pain. So when you've got protracted reflux, when you've got abdominal pain, it is important to consider potentially to do an endoscopy. The second syndrome, which is also very important to recognize, is FPIES. FPIES is food protein-induced enterocolitis syndrome. What is FPIES? You've got chronic FPIES and acute FPIES. In chronic FI, you've got the regular consumption of an offending food, in this case, milk. And if the child is having based milk products all the time, he will have chronic digestive symptoms. If the child stops drinking or eating dairy products, and if all of a sudden he takes again milk, then the reaction may be very severe with uncontrollable vomiting, diarrhea, lethargy due to dehydration. This syndrome is non-Ig mediated. The treatment is not adrenaline. The treatment is rehydration. So again, when you see a child and when parents describe acute severe vomiting, you need to think about this entity, food protein-induced enterocolitis syndrome. And at last, when we discuss and describe the allergy to milk, we have to think about multiple food allergy. Allergy to milk is quite frequent. And when a child is allergic to milk, he may be allergic to any other food. And it is now recognized that very often when you've got cow's milk allergy, you've got also multiple food allergy. And this entity was recognized, I'd say, 30 years ago. We in France were able to see that when children were allergic to extensively hydrolyzed formula, actually they were needing an amino acid formula, and very often they had multiple food allergy. And almost in the meantime, in Australia, David Hill saw exactly the same kind of syndrome. So now we've got a higher knowledge about multiple food allergy, but this was recognized approximately 30 years ago. And this multiple food allergy may be Ig mediated, it may be not Ig mediated, and very frequently in one child, you see some offending food for which the mechanism is Ig mediated, and some offending food for which the mechanism is non-Ig mediated. So you see, I think that it is important and it is feasible to recognize cow's milk allergy. And why is it very important to recognize cow's milk allergy? Actually, cow's milk allergy develops mainly during the first months of life. Here, as you can see, during the first 6 months of life. And this is a period when the child is fed exclusively with breast milk or with formula. And if there is an impact on the height gain or on the weight gain, that there is a long-term risk on growth if the correction is not made immediately. Here is one of my personal cases. You see, I'm sorry, it is in French. Here you've got the weight, you've got the height. The child went to see me because of this difficulty in weight gain. And you can see here that the beginning of the weight loss was at around 4 months of age. The child at that time was fed with a formula. The pattern was quite severe, so that we decided to use an amino acid formula. And you can see that there is a catch-up weight, you can see here. And you can see that in the same child, following the weight deficiency, we had also a decrease in height gain. And the problem that we have is that when a child has got a decrease in height gain here, we do not know exactly if there will be a catch-up, a complete catch-up, or if the catch-up will be only partial. You see that, you know that in clinical trials or in different surveys that have been done, the final height of children who have been allergic to cow's milk is lower than the final height of the population which has not been allergic to milk. So that you see here, if we do not recognize immediately the height deficiency, this may impact the later growth of the child. So it is important because, especially to recognize cow's milk protein allergy, especially because now we've got a wide offer in formulas and a better of understanding on the diet, which may accompany this wide offer in formula. Actually, now when a child has got cow's milk allergy, we may use a formula which is totally appropriate for the feeding of children with cow's milk allergy. The composition of these formulas is delineated by different guidelines, especially in Europe, so that for nutrition companies, I mean, the amount of the different mineral, vitamins, and so on is very precise, so that the child will not have any deficiency. But the important point is that the protein part may vary. You see, you may have for children allergic to cow's milk, you may have product coming from milk, from casein or from whey protein. You do not use the casein or the whey protein, but you do hydrolyzate, extensive hydrolyzate of casein or extensive hydrolyzate of whey protein. And these hydrolyzate, this formula based on this hydrolyzate are EHF. You may have also amino acids, because very often, not very often, but in 10% of cases, children allergic to cow's milk are also allergic to extensive hydrolyzate. So that in these children, you need to use a product without any protein coming from milk. And this is one of the reasons why the amino acid formula have been designed around 30 years ago. But now we've got something new. We can also use not only the amino acid formula, but we can use also the rice formula. In this H or F, we use a protein based on rice, hydrolyzed rice actually, and this hydrolyzed rice formula are expanding now because they've got a good taste, because they're adapted, and because basically I think that people like this kind of formula. So now we've got different formulas. We've got the EHF, we've got the rice formulas, we've got the amino acid formula. How to use them? There have been different clarifications published, one of them by the World Allergy Organization, the second one of them by the EBSCAN, the European Society of Pediatric Gastroenterology and Nutrition. You've got here a diagram showing what you can do when you have a child with potentially cow's milk allergy. It's a little bit complicated. If you look at the paper is widely available freely, so everybody can read that. We can try to synthesize that. How to use a formula. When the child is breastfed, of course, you will not feed the child with a cow's milk-free diet, a formula without milk. You will ask the mother to go on with breastfeeding, and you will ask the mother to remove from her own diet any product containing cow's milk. If the mother does not drink any milk or does not take any dairy products, then you need to add to improve the diet of the mother by adding calcium and vitamin D. If a child is formula fed, then you can use in mild to moderate symptoms extensively hydrolyzed formulas or hydrolyzed rice formula, EHF or H or F. And when you've got severe symptoms or anaphylaxis, you use an amino acid formula. So this is one of the means to sum up, let's say, the clarification based on different guidelines. Again, you've got I showed you the different proposition of Drachman on one side and EBSCAN on the other side to explain how to use the different formulas in different clinical presentation of cow's milk allergy. Let's look at the EBSCAN consensus, which is for me quite clear. You can see here that when you have cow's milk allergy, cow's milk derived EHF is the first choice for a therapeutic elimination diet. So you use an EHF. You use an AAF, which is more expensive in severe cases, or when you do not have a good response with an EHF. And the H or F can be now considered as an alternative to cow's milk derived EHF. So basically, you can use an EHF based on cow's milk, and you can use a rice formula. And AF are only in cases when you've got a severe problem or when the child is not able to drink, or when you do not have any improvement when the child is drinking the EHF based on cow's milk. These formulas that are being used for children have got to be absolutely safe. For a formula to be safe, you need to have the formula being tried in a clinical trial. And the clinical trial will look at two different important points. The first one is hypoallergenicity. The formula that is going to be used in a child with cow's milk allergy needs to be tolerated by at least 90% of children having a proven cow's milk allergy. And the formula has to be able to relieve the symptoms of cow's milk protein allergy and assure an improved quality of life. This is for the hypoallergenicity of the formula. But also, the formula has to be safe. Safety, what does that mean? It means that the formula has to ensure a proper growth. So, all the formulas that are going to be used in children with cow's milk allergy have to be tested in a clinical trial, and this clinical trial will analyze the hypoallergenicity and will analyze the safety, basically, actually the ability of the formula to provide to the child a normal growth. So this is for the treatment using a formula. But what is also interesting, and I think quite new now, is how to do the complementary feeding, or how to reintroduce milk in children with cow's milk allergy. And to do that, it is important to take advantage of something which is new, which was not really known 30 years ago, the fact that when you bake the products, you reduce the allergenicity. And when you bake milk, you can reduce the allergenicity of baked milk. It is important because you cannot feed the child only with the formula after 4, 5, or 6 months of age, because at 5 or 6 months of age, you've got typically the complementary feeding which begins. And during this period, you need to have a balanced diet. And sometimes it is difficult because to do the diet properly for the child, because infant and new children are curious and they are often eager to try new food, especially the ones that are eaten by the family. And when you try to completely eliminate dairy products from the diet, it is difficult to maintain, and sometimes it may be even counterproductive. And this is very important to understand, because many children exhibit a long-lasting transition phase during which milk and dairy products are only partially tolerated. You see here a synthesis paper which has been published quite recently, which shows how the length of the potential milk-limited diet. When you look at the problem of children with cow's milk allergy, you see that in some clinical trial, in some survey, you've got quite a rapid decline. You see that in some survey, the decline is much less rapid. And when you analyze when you've got a global view on all this, you see that in children who have been cow's milk allergy, very often you may have a problem which is long-lasting, even until the teen age. So during this period, during which the child has got, let's say, a problem with milk and is not able to have a normal dairy product consumption, it is important to know what to do. It was published in 2008 by Anna Novak-Vesgrin. It was a very interesting paper. the fact that the majority of children with cow's milk allergy were able to tolerate heated milk. Actually, you see in baked milk, you see some cakes that have been cooked in an oven, and it appeared that in children with cow's milk allergy, it was possible to feed them with this baked milk, actually baked with wheat. Now we know more and more about the effect of cooking or baking on the acceptability of milk product in children with cow's milk allergy. And I would like to try to synthesize this with this slide. You see, baking milk is able to reducing allergenicity. So when you want to feed a child with a dairy product and the child is allergic to cow's milk, you need to bake milk. You make to bake milk, and you've got basically two different systems. One of them is using a matrix, such as wheat. This is what you do in a cake. Wheat is interesting because it's got a protein which is sticky. The gluten is sticky and sticks to the milk protein, so that when you eat the muffin, the release in the intestine of the milk product is reduced because of the sticky ability of gluten to retain cow's milk protein. So here you see baked milk using the matrix with milk. The other way to bake milk, but without meat, is manufacturing a hard cheese. How is it done? Hard cheese, you've got cooking and you've got also enzymatic digestion, actually fermentation. And the experience that we have now is that very often hard cheese is also very well tolerated by many children with cow's milk allergy. So you see, baking milk, with wheat, or with the process of making a cheese, these are the two ways that can be used now for feeding children who are allergic to cow's milk. And now, based on that, there has been the publication of the milk ladder. The first publication was done by Karina Venter, who is a very distinguished research dietitian. And you see that the milk ladder shows how to go for a child who is allergic to cow's milk from a product which is highly cooked, like biscuits, to a product like cheese, to a product like fresh milk but fermented, like yogurt, or to a product like to fresh milk. So you see the different steps. And when you try to reintroduce milk, you go from the first step, biscuit, to the second, third, etc., going to hard cheese, going to yogurt, and then going to fresh milk. The milk ladder was initially invented for non-IgE mediated allergy because you can do the introduction at home. There is no risk of anaphylaxis. But it might be interesting to see if the milk ladder may be used also to reintroduce milk in cases of IgE-mediated allergy. And we can discuss that because it has been now expressed in a recent publication done by DRACMA. How to reintroduce milk, how you going to use the milk ladder at home, or can you do are you obliged to go to the hospital to the milk oral challenge? Well, how to decide? You can look at this paper, for which the first author is also Karen Demeter. The second one is Rosanne Meyer, who is also giving a presentation in the same meeting. Hello, Rosanne. And you see that in this presentation, you've got the arguments against home milk reintroduction and in favor of home milk reintroduction. So against reintroduction of milk at home, you've got a child more than 5 years old who had prior anaphylaxis or who had severe FPIES, this syndrome with acute vomiting. The child who had a low previous reaction threshold, the child who was reacting to very low level of milk, a child who still reacted to baked milk. This may happen, of course. And a child with poor control of asthma, because anaphylaxis may manifest with asthma, so that if the asthma is not good, it's not controlled perfectly, then you may have a problem with asthma. And of course, if you've got a high level of diameter of skin prick test or a high level of specific IgE, then it is against the reintroduction at home. And also, you have also the ability of the parents to be able to monitor symptoms. Some parents do not want to have the reintroduction being done at home because they are scared by the potential problems. So you need to have a caregiver. If you want to go at home, you need to have a caregiver who is really accepting the latter approach. So in favor of whole milk reintroduction, you've got young children, no anaphylaxis, food protein-induced allergic protocollitis means that you've got blood into stools, you've got high reaction threshold for baked milk. I mean, the child is able to tolerate baked milk even at a high level. They're able to amount to have baked milk without symptoms for small reaction. A good control of asthma, so that you will not have a problem if there is a reaction, an allergic reaction. And of course, in children with IgE-mediated cow's milk allergy, a small diameter of the wheal during the skin prick test, or a small level of cow's milk specific IgE, or a very important decrease of the level of cow's milk specific IgE. So you see that now I think this paper this presentation is very important because it allows very precisely to decide, because it is very complicated in some countries to try to find a place in the hospital to do the food challenge, to try to decide with the parents, of course, with the parents, if they want to go to the hospital or if they accept to do that at home. And I can say that for myself, I discuss with the parents, and very often now we do that at home, and it goes very smoothly. Of course, if you've got an IgE-mediated cow's milk allergy, and if you do that at home, you need to be sure that the parents are confident and that the family is equipped with all the treatment that are needed in case of acute reaction, including epinephrine. So when you do this modification of the diet with a progressive reintroduction of milk, I think, and I would like to insist on that, it is important to keep the formula that the child is still having and the child was able to tolerate. When you have a child with cow's milk allergy, sometimes it is a little bit difficult to find the formula which is perfectly adapted. And if a formula is perfectly adapted for a child, if a child is happy with the formula, then you go on with this formula until the end, until you completely drop off the replacement formula. Some people say that it might be interesting to use a partially hydrolyzed formula. I think that actually this partially hydrolyzed formula have no place in the milk ladder. If the partially hydrolyzed formula is tolerated, then it means that the child is already able to have baked milk products. And also it is important to know that many clinical trials have been done on partially hydrolyzed formula, but no clinical study has been done trying to show any benefit for cow's milk allergy during the milk reintroduction using, for example, the milk ladder. So the message is, if the child is good with the formula, you keep the formula until the end. So in conclusion, I would say that for the diagnosis of cow's milk allergy, we need to be aware of the fact that symptoms are multiples. They are frequently considered non-specific. But in an infant, when you've got reflux, you do not consider only reflux. You consider reflux and other symptoms. And if you've got reflux and eczema, this is not specific, but quite specific. You need to recognize eosinophilic esophagitis if an infant has got very severe reflux and if an older child has got abdominal pain. We need to be able to recognize FPIES. This is when parents describe a very severe vomiting. And we need to recognize multiple food allergy. When with the diet eliminating cow's milk, you've got the symptoms improving, but not really disappearing, meaning that there is a need for another elimination, for example, wheat or I don't know, egg, etc., etc. And in this case, you need to use an amino acid formula. For the dietary management of cow's milk allergy, it is important to encourage breastfeeding. It is important also to, if the child is formula fed, to choose an adapted formula, which may be an EHF, an HRF if the cow's milk allergy is mild, or an amino acid formula is the cow's milk allergy is severe. It is important to monitor the growth on a regular basis. You have seen that if you do not do that, it may impact the final growth of the child. And of course, it is important to ensure an appropriate nutritional counseling. If I have only one take-home message, I would say that in an infant, either formula-fed or breastfed, reflux is a high probability of cow's milk protein allergy. Eczema, this means a high probability of cow's milk protein allergy. But if you've got reflux and eczema, you've got almost certainty of cow's milk protein allergy. And you check the growth curve. If in addition to that, you've got a weight decline, that you can be sure that there is cow's milk protein allergy. Thank you very much for listening to me.
So perfect. If you want, we can stop sharing your screen.
No, it's okay. For me, it's okay.
Yeah, it's perfect, everything. So if you want, we can stop sharing the screen so we can do the recording of the frequent asked questions.
Okay.
There we go. So what we're gonna do, let me just tell them in Spanish. Saben que les cambié la primera pregunta, se las volví a escribir todas en el chat. ¿Pueden volverla a actualizar, por favor?
Sí, ya voy ahí entonces.
Sí, te cambié las tres.
Últimas versiones, ¿verdad?
I can see the question of my screen. That's right.
Yes. So what we're gonna do is like just say some of the questions after this presentation, or the most common questions are how to implement this in clinical practice or something like that, and then you are gonna read the question and answer it. So we are gonna have 3 questions.
Okay.
Okay. So we can begin with the first one. Let them just so it's gonna be like that. In everyday clinical practice, which common signs and symptoms in infants should prompt suspicion of CMPA? And then the second question, si quieren ponerle la segunda pregunta para que de una vez la lea, the second question would be, why is early diagnosis and treatment of CMPA critical for infant growth, and how should pediatricians implement it in clinical practice? Y le puedes poner la tercera, gracias. And then the third question would be, how to implement milk ladders in clinical practice and effectively guide parents through the process at home.
Okay.
It's good? Yep. So perfect.
Okay. In everyday clinical practice, the question is, in everyday clinical practice, which common signs and symptoms in infants should prompt suspicion of cow's milk protein allergy? In my experience, I think in the experience of the other people, one of the main symptoms is reflux. When a child has got reflux, I think that it is important to think about cow's milk allergy each time the child has got reflux. And when the child has got reflux, you look at potential other symptoms. Very often you've got crying also, and very often you've got eczema, or if you do not have eczema, you've got dry skin, and the association of reflux and eczema or dry skin and the presence of, for example, of problems for sleeping disorders or colic, this for me is an association which should prompt the diagnosis of cow's milk protein allergy and lead to an elimination diet. Actually, in this kind of symptoms, it is the association of symptoms means that you do not have Ig-mediated allergy. It is non-Ig-mediated allergy, so that you do not need to go to the skin prick test or the specific Ig measurement immediately. You need to go to the elimination diet, and with the elimination diet, you will see if you've got an improvement and you will have the proper diagnosis. I need to remember you, it's not done all the time, but it is underlined by the different clarification and guidelines. The fact that when a child is, when you start an elimination diet in a child, when you think about cow's milk allergy, it is important to do a food challenge after 2 or 3 weeks to see if the symptoms reappear and to be sure that the diagnosis is true and that you are not going to an overdiagnosis. But basically, if you've got reflux, if you've got eczema, if you've got colic, then almost all the time you will have relapse of symptoms, and this will mean that the child has got cow's milk allergy. The second question, please. Yes, thank you. The question is, why is early diagnosis and treatment of cow's milk allergy critical for infant growth, and how should pediatricians implement it in clinical practice? Now we've got curves and guidelines which are based on feeding of children being breastfed. This has been done by WHO, and we know exactly which kind of growth we can see for the height gain and the weight gain in children, and the basis of this line is done on children who are breastfed. So we know exactly what is the growth in the first months of life. And actually, cow's milk protein allergy starts during these first months of life at 3 or 4 or 5 months of age, very often, most of the time. And this is a period when you have a problem in the weight gain and then in the height gain. So it is important to have a measurement of the child. And if the child is not following the appropriate curve on the diagram, it is important to try to see or to know if the child has got also reflux, or if the child has got also eczema, or if the child has got feeding problems or colic, and then to try the elimination diet to be sure that we do not take care of this weight delay or of height gain delay too late. If we do that too late, then we will have an impact on the final growth, and potentially this will be responsible for a final height that will be lower than normal, or than the one that was expected according to the gene of the child. So the question is how to implement milk ladders in clinical practice and effectively guide parents through the process at home. I do that. The milk ladder, I'm using the milk ladder absolutely all the time in parents, and I explain that very precisely. I explain why cooking is reducing the allergenicity of the proteins. I very often take the example of egg, because when you look at the egg white, when you see egg white, and when you compare egg white when it is cooked or not cooked, you see a big difference. And I explained that for the proteins allergenicity, it's the same. The difference is very important. So it's important to explain that the modification of the reactivity to milk is decreased by the cooking, and the more you cook the milk, the more you reduce the allergenicity. For example, in biscuits, which are cooked at a higher temperature than, for example, muffins, you have got a higher reduction in allergenicity. So that if you want to start a milk ladder, you will not start with muffins, you will start with biscuits. And if it works with biscuits, then you will go to muffins. And if it works with muffin, then you will go to hard cheese. But if, for example, it does not work with muffin, it works with biscuit, but not with muffin, then you will not go to hard cheese. You will wait a little bit and then start again. And usually parents understand that very nicely. And when they send me emails, because I've got a lot of communication by email, they explain to me at which step they are so that I can give my counseling whether to go or not to go further in the milk ladder.
There we go. Perfect.
Okay.
Yeah, I think everything was.
So you got everything.
Perfect.
It's okay.
Yes.
Okay.
Yeah, I think everything it's perfect. If we need anything, I don't think we will do, but I will reach out and let you know.
Yeah, you will let me know. Yes. Okay.
Yes. So they are gonna edit it and they're gonna put the translations on, and then if I need anything, I would let you know. But I think everything was right. If you could send me your last presentation just to have it, for the approval things.
Yeah.
The one that we presented. So